morning to all of you. A warm welcome to our Zoom webinar organized by GMO Sri Knowledge Academy. Today our lecture is going to be on management of COVID-19 in resource-poor setting beyond the level 1 care during third wave. Kindly mute your microphone and turn off camera during the presentation and use the chat box to clear the doubts at the end of the session. Now it's my pleasure to introduce Dr. Himal Kalabarachi, Acting Consultant Physician, currently attached to District Hospital, Hikkaduwa. Over to you, sir.
Thank you, Chachurika. I think you can hear me well. First, I would like to thank Sri for giving me this opportunity to share our own experience on managing the COVID-19 patient in resource-poor setting. Today, my talk regarding managing COVID-19 patient on a resource-poor setting, especially during a third wave. So, I'm Dr. Himal Kalabarachi, an acting consultant physician working in 4 COVID centers with my fellow VP, Dr. Amila. So this is my outline of the lecture. So for management, we need to have some kind of understanding of the disease. So second thing is clinical features and diagnosis. Then the setting of the treatment center, management, symptomatic patient, admission, transfer and discharge, follow-up and a couple of take-home messages. So the COVID-19 disease. So before we go into management, we'll discuss briefly regarding the management, regarding the disease by itself. So I just quickly go through this epidemiology slide, and this actually start with the China and different mortality, morbidity comes from different countries, and you might already know these things. And there are different mutated virus genes, especially in our country. 80% of time now we have UK variant B117, and there are other South African, Indian, and other variants. So what is the transmission? There are 3 main transmission for this disease. Airborne is the main, and droplet transmission and direct contacts. And majority of transmission occurs in globally in asymptomatic or pre-symptomatic stages, which is almost 60 or 59%. And other important thing is infectious risk rapidly decline after onset of symptoms. So basically, when you meet a patient, pre-symptomatic patient, then when you meet a patient in a hospital, so they are compared to the hospital patient is less symptomatic, less infectious. So incubation period is around 5 to 6 days, and it can vary for 2 to 14 days. So a bit about pathophysiology. So this is one of the most important slide in my talk. So we have 5 phases: incubation period, viral symptomatic phase, and early inflammatory phase, and secondary infection phase, and multi-system inflammatory phase, which is we have at the 4th week. So when you see this chart, you can see the viral RNAs appearing. That means viremia, viral replication is highest with first week, and in the second week it's rapidly decline, and almost third week is coming to the 0. And from the onset of second week, the antibodies start to rise, and which is initially IgM, then IgG. Then at the third week, it will be detected, onset of third week. So this is the, again, graphical explanation. So depending on this pathophysiology, certain treatment will be indicated in different stages. Especially if you start with steroids, this initial period, it will be really harmful. So as I mentioned, so these are the phases: incubation period, viremic phase, that means an early inflammatory phase, secondary infection phase, and hyperinflammatory phase. So this is about, sorry for that one. This is about uh, the pathophysiology of COVID pneumonia actually. So what's happening in the lung? First, virus will proliferate in upper respiratory tract. Then most of the patients will settle with that, and about 10 to 15% it will go through the uh, airways and the lower respiratory tract. Then the cytokine storm develop, then inflammation will come to the place, big role, then ultimately which called diffuse alveolar damage, which will give rise to the COVID pneumonia and ARDS. So this is two main pathophysiological phenotypes we have identified. We called light type and heavy type. So light type will be we will observe in a early phase of pneumonia, 5 to 6 days, and which will has a low resistance lung and low weight lung, and still the lung involvement is very minimal. When you go along the process, if you don't treat appropriately, it will go to the second phase, so which has extensive bilateral pulmonary infiltrates. So this is the pathophysiology of endothelial damage and the hypercoagulation and thrombosis. So this is what we start with the actually start with endothelial damage and myocardial damage and hypercoagulation and platelet activation, and all depend on the cell death and hyperinflammation, which will ultimately result uh, thrombosis and thromboembolism. So what are the clinical features? So these are the clinical features of mild disease: cough, fever, myalgia, headache, dyspnea, sore throat, and these most of the symptoms are already. And some people are going to diagnose the loss of taste, loss of smell with the COVID, but those are not very common symptoms. And these are the features of moderate to severe disease. One is respiratory failure, the pneumonia, and hypercoagulability will results both the respiratory failure, and rarely you can have a pneumothorax and pneumonia, especially intubated or when you use in non-invasive ventilation, and cardiac and cardiovascular complication like acute MI, cardiomyopathy, arrhythmia, and especially since the sinus tachycardia very common in these patients, and heart failure, thromboembolism, uh, especially patient with very high risk of thrombosis. We will have to expect thromboembolism. So this could be the commonest one is a venous thromboembolism, and there are arterial thromboembolism as well. Then the neurological diseases, neurological manifestation like encephalopathy, peripheral neuropathy, and acute Guillain-Barré syndrome, and critical illness myopathy and neuropathy is very common in these patients. And secondary infection. This is the second bad outcome we expect in a COVID-19 patient. And especially this delirium and confusion state we have noticed in a lot of patients, especially patients who are ill at the pneumonic stage. And then after they recover, we expect some of post-COVID syndromes. And these are the absolute risk factors for the severe disease. One is increasing age, male, sex, viral strains, genetic factors, and we lot of things. The same family members getting a lot more severe disease, like father, son, both developing severe disease, and comorbidities as usual. We know cardiovascular disease, chronic obstructive pulmonary disease, diabetes, cancers, chronic kidney disease, and solid organ hemolytic transplantation people, and obesity, smoking, as well as pregnancy also considered as a high risk factor. And these are the laboratory findings which tells us uh, the severe disease. One is this lymphopenia, other one is thrombocytopenia, and elevated LDH and other inflammatory like CRP, ferritins, and if you have a facility do the interleukin 6 levels, and D-dimers, elevated prothrombin, troponins, and CPK values, and liver enzyme and serum creatinine, those are signs of worst outcomes. So diagnosis, we have three types of tests. One is nucleic acid amplification, that means real-time PCR, serology, and we have a rapid antigen test. So this about the imaging. So we do this imaging for the confirmation. So chest X-ray is not very sensitive in early disease, and when it go along, you can see reticular reticular nodular opacities, which is basal predominant, subpleural, and later usually consolidation. And you can see there is yellow arrows, some reticular opacities, and the white those are the white arrows. The black arrow shows linear opacities. And when you come to the right side, my right side hand, these are the signs of consolidation, patchy opacities. And people have used lung ultrasound, but it has kind of really good sensitive, but it's not very specific, because these B lines and disappearance of A lines and those things we have seen in many diseases, especially in heart failure. And irregular prurine, subpleural consolidation, and those are the signs. If you see the fluid diffusion in ultrasound, this suggestive of alternative diagnosis. So these are the confluent B lines you see in a right hand side slide. And its left hand, you can see the yellow arrows, and these yellow arrows, you will see the consolidation lines, and this arrow shows disappearance of pleural markings, and these are the signs of consolidation we see in ultrasound, lung ultrasound. And HRCT is one of the very specific tests you can confirm the diagnosis. The commonest thing in early disease is a ground glass opacity. And when you go along, you can see more consolidation and adjacent pleural thickening. And this is the diagram we can see the early disease when you go along. What we have, the progressive disease. So first thing is ground glass. Within 4 days, you can see that. In 5 to 8 days, you see crazy paving pattern with the ground glass. And then after 9 days, you see the consolidation focuses of foci. Then the ground glass opacity and line consolidation we will see in a later disease after 2 weeks. So these are the graphical, these are the photographs of the HRCTs. You can see here only the ground glass opacity. Then you go along, you can see these are the crazy paving appearance. This is the foci of consolidation. You can see the in circles. So in the last one, you see the with the ground glass and for a lot of foci of the consolidation. Okay, so next things we are going to discuss what is the setting of a treatment center. Just the care given at level 1 and level 2. All right, this is the current situation. And up to today, we have about over 200,000 cases and over 2,000 deaths. And we have recovered patients about 1,080. 184,090 recoveries, and active cases or suspect cases currently on the way to treatment center or under treatment 32,000. And in government centers, we have about 188 centers, level 1 and level 2 103 centers, and level 1 centers 85 centers we have here. And total number of beds are 22,586. About 10 to 15% of our patient will develop severe disease. So this is one of the graph which is shown by our epidemiology unit. So which has shown a graphical presentation of current situation of Sri Lanka. So this is the level of care in government and the private sector we will receive. So level 1 is intermediate care center, level 2 is the selected hospital which VP cover, consultant coverage. The level 3 centers are the COVID-19 designated specialized centers or tertiary care hospitals. So this is about the intermediate care centers or level 2 centers where we work. The initial function of initial function of these centers were as a quarantine facility. And when we have a higher number of cases, it was turned up into the uh, treatment centers. Then we have a government and private sector, and or we have a private and government partnership centers. So they usually these level 1 and level 2 centers manage very high number of patients, but we running with very limited capacity and resources. So intermediate care center or level 2 centers, we have specific goals. First, healthcare provision for symptomatic or mild symptomatic patient, prevention of disease spread, optimize medical illness such as NCDs, and observe for clinical duration, arrange screening for test negatives. So these things have rapidly changed, and we had to start treat the symptomatic patient even at the ICC during third wave. So this is the setting of the treatment center. In a government, we have wards. In private sector, we have rooms, and this is one of the important place in the treatment center, which is the observation chamber. We keep the monitors and ECGs where the patient comes. Initially, we observe the patient from the observation chamber. Then the operating room, we keep all the records, drugs, and VHDs, and dunning and doffing area. So all the areas of treatment center divided into three zones: green, red, and buffer zones. So, for example, the green operating center is in a green room area. The red zones are the ward and rooms, and buffer zones are the dining and doffing area. So how we exactly work in ICC? So we have a medical staff, which is usually divided into two teams, and working as a roster basis and do the twice daily ward rounds. And we communicate with the intercom system all the time. And we have prepared plan for emergencies and good transport facilities, especially ambulance and supplies, and dedicated secondary care facilities for transfer patient if deteriorates, and close center to handle the acute medical and surgical emergencies. And while in daily assessment, we our main target to detect debilitated patients as well as important detect respiratory deterioration. So the basic equipment are the usually for any ward. So management of the ARV equipment, IV access, emergency drunks, saturation probes, and other necessary equipment as well as PPs. So when we go along, we need this stuff to manage our patients. So adequate oxygen supply, especially oxygen delivery equipment, venturi mask, nasal cannulas, NRV mask, as well as the oxygen regulators, cylinders, and equipment like we need for intubation and ambu ventilation, and the sucker machines. And for the IV access, we need all the cannulas, emergency drugs, and for drugs, especially, we need antibiotics, heparins, and other special medical emergency drugs. So we need these facilities to manage treatment center, especially CBS machines, ECGs, laboratory investigation available for close by center, portable X-ray, ultrasonic scan machines as well. So for the clinical care delivery, this is our main target in treatment center or intermediate care center. Categorize a patient, special attention to debilitated, twice daily saturation check is in all patients and which should be documented each day, and assess all the chronic and acute medical conditions, and more simply debrief the updates to the team and handover. So out of all things, this is the most important part of the any COVID-19 treatment care center, which is a dedicated staff who will available for patient care at any given time. Out of this dedicated staff, whatever machines, whatever equipment, whatever facility you have is useless. So we'll discuss the management of symptomatic patient, especially in a resource poor setting. So this is what we do. So we detect this respiratory deterioration as a first place. Then we have to know first what are the disease severities. So this is taken by National Health Services in UK. So our main target is detect the patient at the moderate level of illness. We have a evidence of lower respiratory disease with the clinical assessment or imaging, and who has oxygen saturation more than 94. And before they go into, if you can detect at patients this level, you can save a lot of life with the minimal invasive therapies. So the next main important equipment is pulse oximeter. Many of pulse oximeter you will come across with in the market shows false very high or low values. So especially when you go along this machine, you have to be very careful about waveform, wave strength, and you have to always double check with the normal patient. And you have to calibrate these machines after 1000 to and 2000 readings. So there are three main category of patient with the saturation drop. First is symptomatic patient who is coming in the shortness of breath, who has saturation less than 96. And second category is asymptomatic patient who has less than 96. Some people are calling these people happy hypoxic patients. And our third category is symptomatic patients who has saturation more than 96, but they will have a exertional desaturation on walking as well as when they're doing sit-ups. So there are two ways to do exertion desaturation. One is walking 40 steps or 6 to 8 sit-ups. So after you doing it, you immediately check the saturation. It will be definitely, if it's COVID-19 COVID involved patient, it will be more than 3% drop you can see. So this 3% drop is very important irrespective of initial value. So example, you do the checking today morning, and 2 days after you check it is in a rat rest is 96. So your initial value is 99. Your 2 days after value is 96. So this 3% of which warrants there's something going on this patient. So how you do the clinical diagnosis in a resource poor setting? So first thing is there are two things should be there to diagnose a pneumonia clinically. One thing is clinically detectable hypoxia. So this is what I discussed in previous slide. Either patient should be symptomatic or asymptomatic with the low saturation, or symptomatic patient with exertional desaturation. And typical examination findings, which will give you a good clue in 99% of time this patient has gone into the COVID pneumonic phase. And next level investigations are confirmatory evidence by X-rays and HRCT. And your decision will be supported by biochemical evidence, elevated CRP, usually 30 to 150, as well as thrombocytopenia, which is available in a resource poor setting. All right. So these, what are the examination finding on the chest? So these are the findings which will tell you this patient is in COVID pneumonia phase. So first thing is bilateral symmetrical signs. The second thing is crepitation is a very common findings, and predominantly which is basal, and these signs are changing on the dependent position. For example, if you turn out the patient in the prone position, the fluid will go on into the ventral aspect of the dependent position. So the daily fluctuation of signs are very important to get the clinical picture as well as clinical deterioration. So these signs, when you compare to the other diseases, these signs are clinically disproportionate to the level of hypoxia when you see. So for example, if you see the heart failure patient, so they are, when we have a low saturation, when the patient has at least half of the lung involved, or when you have any other disease, you will have a low saturation, we have a hypoxia, or ill patient. When you see, we have a wide disparate lung signs. But comparatively in a COVID patient, you have a clinically disproportionate signs. That means signs are, I mean, the hypoxia out of proportionate from the signs. Those are the major sign of COVID-19 pneumonia. The main point is clinical disproportionate findings. So if you have these signs, we should exclude the, you should find any other focus, any other diagnosis, any other alternative diagnosis. One is unilateral or asymptomatic signs. If there's no hypoxia, or if you have clear lung fits, there could be two things: either patient not in COVID pneumonia, or it can be even embolism. And predominantly other lung signs such as host capitations, valvular capitations, or bronchi, and signs of pleural effusion suggestive of alternative diagnosis as well, and features of fluid overload. So these are the pitfalls we will usually come across when you managing the patients. So if you have a patient with the fever, low blood pressure, thrombocytopenia, or positive dengue antibodies, so which usually suggestive of dengue, but we have to know the positive dengue antibodies can be seen in a COVID-19 patient, and we have seen enough. And fever, low blood pressure, thrombocytopenia, high CRP, especially shortness breath, you will see, especially in southern and western provinces, the leptospirosis, even with the pulmonary hemorrhages. And fever with low blood pressure is a signs of bacterial sepsis, as well as by anyway bacterial infection. And there are other respiratory conditions with the low saturation, especially heart failure, chronic respiratory illness such as bronchiectasis or ILD. So you have to be very cautious when you're diagnosing clinically the COVID-19 pneumonia. You have to consider all the possibilities and exclude very carefully the COVID-19 pneumonia clinically. So management, the management strategy is detect the patient early, and second, the important one is to treat the patient early and the come out early. So detect early, treat early, come out early is our main strategies of management of COVID-19 patients. So what are the treatment options we have? So it all depends on the pathophysiology of COVID-19 when we discuss. So there are things you can use in early disease, which is shows antivirals, monoclonal antibodies, and vaccines. Vaccines currently being used in Sri Lanka, but others, immune modulators or other antivirals or monoclonal antibodies not available in Sri Lanka. So what we have is immune modulators such as steroids and other drugs like IS6 inhibitors, and anticoagulation we will use in from the second weeks, and which is start with the early inflammatory phase. So if you ever start the immunosuppressive drugs, especially steroid, in during the first week or before first week, it will cause really harm. It will cause real harm to the patients, and it may cause death of your patients. So these are the specific therapies we use for COVID-19. So first thing, the steroid, which will shown stop the disease progression and the improve survival. So major landmark trial is a recovery trial. Dexamethasone you can use. Dexamethasone is the drug they have used. You can use other steroid, hydrocortisone, prednisolone as well. The usual dose they have used is 6 milligram for 10 days. But on the practical experience, we know the patient's steroid dose and duration solely depend on patient clinical condition. We have used uh, even 3 milligrams daily doses, as well as more higher doses in a patient with that's a very high inflammatory response. So steroid dose totally depend on a patient's clinical condition. So this is the evidence of uh, landmark trial which we have discussed, recovery trial. You can see the mortality benefit. Uh, this is about all patients. The right hand side we show the ventilated patient which has shown clear benefit with the dexamethasone group, and the second one which has shown dexamethasone group with the usual care with the oxygen therapy. which has shown clear benefits. And this slide you usually see dexamethasone group actually shown harm, doing harm when patients who are not dependent on oxygen. So don't use steroid who are not symptomatic. So this is my only message for steroids. This is my only and most important message when you treat the patient. Do not misuse steroids. And using early disease has clearly shown significant harm. So this is a tocilizumab. I'm not going to discuss this about this drug because it's not available in a resource poor setting, and there are clear criteria to start these drugs, and you should take other consultant or respiratory physician opinion before starting these drugs. And other specific therapy, especially we use antibiotic intravenous or oral if it's indicated, and we have to add some adequate anticoagulation for this patient. If a patient is have a high D dimers, you use therapeutic dose. If a low D dimers, you use prophylactic dose. And if you don't have any evidence of D dimers, you better use therapeutic dose at least couple of days till the recovery. And we use aspirin for high risk patients. and and the second important thing, respiratory support. So you have to keep the oxygen saturation around 90 to 94, and this is actually is a rough target. You can use oxygen with according to symptoms. If you, for example, if a patient is saturation 94, still patient is symptomatic, you might have to use oxygen. But if consider if a patient is saturation 90, 91, but still patient is not dyspneic, his respiratory rate is normal, you might not have to use any respiratory support such as oxygen. So there are three ways we use oxygen delivery: nasal cannulas, mask, and the NRB mask. The most important thing in this patient, the positioning patient, which we use usually, the technique is conscious proning for these patients who need respiratory support. So why we use conscious proning? So this is the graphical explanation. So in a COVID-19 or ARDS patient, they have a fluid in lung which is accumulating dependent position, which will cause alveoli and collapse, and same as vasoconstriction. So your basal, that means the dorsal lungs are not ventilated or not perfused very much, very well. So if you turn back to the prone position, you can see the collapse alveoli will expand and your perfusion will be increased. So if you adjust this prone position, you will see within 1 to 2 minutes patient is improving in saturation wise as well as respiratory wise. So these are the methods you use for conscious proning, technique of conscious proning. So each position you keep the patient about 32 hours. It's very difficult to keep the patient totally, I mean, throughout the period throughout the hospital stay in prone position. First, you have to discuss with the patient. First, make sure they are very comfortable in this position, in these positions. Then the most common position the patient uses is a lateral position. That shows us as some kind of benefit. And the best thing is a prone position. And when you do the work done, you have to teach each patient how to do these techniques. The third important thing in my management plan is fluid management. We have seen a lot of patients who are symptomatic in fluid depleted state. So dehydration, which can cause many harms, including renal issues, lot of perfusion issues, as well as slow recovery. So very important to maintain fluid balance. Oral fluid are usually encouraged, and if not taking oral, you can use some IV fluids without any delay. So when you starting dexamethasone, when you try steroid, you have to monitor the blood sugars. Very carefully you have to monitor blood sugar, especially in the diabetes. And we have diagnosed a lot of patients, previously undiagnosed diabetes, when we monitoring these patients. So before starting dexamethasone, you have to check the sugars. And while on therapy, you have to keep the blood sugars below 180. So if it's not coming to 180, if it's going more than 200 to 12 millimoles, then 216, you have to start insulins to control the resistance. And most importantly, you have to avoid hyperglycemic variability in these patients, which will show very harm when you control the sugars. So other therapies we usually use, these are not very trial proven, but vitamin D3 have been discussed very well in other respiratory illnesses, which has shown low vitamin D has the worst outcome, but we need more trials to ensure this safety and efficacy. But this is the recommendation given by many guidelines, the 15 to 25 micrograms per day or 600,000 units per day. And vitamin C has not clearly shown any benefit or any harm. So people are using these drugs. Vitamin C level C is about 500 to 1500 per day. Using of zinc will be very cautious in some patients because it can you cause many harms like toxicities. It has shown in uh, theoretical setting shows enhancing immunity, but it has shown very if you use very high doses, it can cause copper toxicity, copper deficiency as well. So recommended dose for men is 11 milligram per day, and this 8 milligram for women. So usual preparation don't have these strengths. So these are the ineffective therapy we don't use as a blanket therapy. One is azithromycin, hydrocortisone, hydroxychloroquine, as well as kernels and plasmas. This has never shown any clear benefits, and initial trials have shown many minimal benefits, but this have clearly shown now the recent trials there's no benefits. The other thing is we have to anticipate for the complications. So these are the complications we usually encounter: respiratory deterioration, thromboembolisms, and neurological complications such as acute Guillain-Barré syndromes, peripheral neuropathies, and encephalopathy. These are very common among our patients, and we have come across a couple of cases of sudden cardiac death among our patients, which we couldn't explain why this happened. In perfectly healthy patients as well, we have observed these sudden cardiac deaths. And we have to always expect other medical and surgical complications and emergencies. So these are the one of our cases we manage. Uh, we have transferred for further uh, oxygen therapy and the treatment. This is we have extensive lung damage. Initially, we manage this patient in our center. We transit. You can see most of the lung is involved, and this HRCT you can see he has widespread ground glass with early organizing pneumonia signs. Uh, right. This is another of a patient who has we have recovered from the pneumonia, but unfortunately, with the therapeutic dose of enoxaparin and aspirin, he developed right-sided face arm leg weakness. This is a CT we have done 2 days after. First CT was normal. You can see the massive major vessel exclusion, that's mean MCA infarction in the CT. Unfortunately, due to the complications, even though he has recovered from pneumonia, he has passed away in last week. His age is 35, but he has a major risk factor for the situation, which is diabetes. So this is a common ECG pattern we see usually is these days, S1Q3T3 pattern. And after we see in this patient with that hypoxia, we definitely send for exudopulmonary embolism. This is not specific for this S1Q3T3 pattern, not specific for pulmonary embolism, but if you see this, you have to suspect, always suspect pulmonary embolism in the COVID-19 patients. So when you do the patient care in a resource poor setting, we have adapted new methods to improve patient care because of the restricted approach. So because of infectiousness, we can't go daily to inside our wards uh, daily and frequently. So every patient we can't go by and see patient by ourselves. So for that, we have used in our centers a different methods to enhance the patient outcome, patient care. So what we are using, enabling patient to actively participate in their care. So how we do that? First, we daily give the patient. So when we admitting any patient, we daily give an assessment form. So when they enter into our center, we give one assessment form. In each assessment form, the patient has our nursing officers or uh, doctors has have to document a daily update of the patient. Then it will be carried out throughout the hospital stay. Then the next time in a consultant or next four down team comes, he can see this in assessment form and assess the respiratory or other deterioration. So this is one of the assessment we use in Arachikand hospital. So here you can see patient is blood pressure, temperature, and especially saturation is monitored as well as sugars. So we have BHTs and other records in our operations room, and with this system we can double check our clinical findings and other findings. So this will enhance uh, the patient monitoring as well. So for example, so first day you notice saturation is 99. In third day you notice saturation is 96, which is a significant difference. Or you can see sugar is now high, but you have to call back to the operating room to get down the sugars. But in this system, you can detect by at the bedside assessment, you can detect at the bedside what is the sugar or saturation drop throughout the period. So this is the lower part. The lowermost one is actually belongs to pneumonia patient. You can see the saturation drop of this patient and the clinical improvement clearly. So the next one we have introduced is a group based or family based approach. When the patients come to our center, it's like they are entering their family. I mean, we are giving them to a family background. So we divide our patient to groups, and patient divided by 10 to 15 group each. Then each group has a leader who has reasonable education level and competence, and we communicate as a mass communication through the group leader, and group leader need to attend patient concerns, and they have to individually go and check what are the complaints they have apart from our ward rounds. So each time when we are not available without PP inside, so we can get patient details when they are how they are deteriorating by these group leaders and the group based approach. And this the ward cleaning, washing, and food distribution part is also doing by these groups who are clinically well. And by these group based activities, we can use their active participation for the ward round as well. So during third wave, we needed to have more hand inside. So what we have done, apart from group leaders, we have used some recovered pneumonia patient for the patient care. There are a lot of advantage using the recovered patients. Thing is, they know about disease and they know about the importance of the help during illness, and they know how to put oxygen even, and they know what to do about supportive care, and they know how to keep the patient prone, and they know how to do the ward rounds, and they know they are usually participating in our ward rounds, and it's one of the encouraging things for themselves after recovery. So we will a lot of recovered pneumonia patient for our ward rounds, and you can see by this photo we have a couple of patients around me, and this is you see our one of the assessment form patient is showing to me, and where I noticing some, where I observing some changes of the clinical parameters. And you can see our last week our help group. These all three patients are recovered from very bad pneumonia in our centers. So these patients have done really good help on managing our patients. So this is one of the things we do in our centers when we have a good space. We ask the patient to have a daily walk. There are a lot of benefits in daily walk. One is we can keep their physical strength very well, and we can detect the hypoxia early, and other benefits of sunlight and improving the glycemic control. So the next thing one I'm going to discuss is admission and discharges and transfers. Admission usually the government circulars, positive PCR or RET, and discharge according to ministry guideline. I'm going to discuss in at the last moment. And transfers, there are two type of transfers, which is should be under strict supervision of consult physician from hospital and from the center. So regarding the transfers, I have discussed very well. I have to tell you, the transfers are the worst management step of our system, COVID-19 management, because we have received many patients with improperly handled transfers. Ultimate outcome is very bad outcome we have seen. Even we have 11 days in our RH center. Most of them are responsible for bad transfers. So the transfer should be well planned with well equipped staff, adequate oxygen, as well as emergency ducts and equipment. Receiving the team should be clearly informed regarding the clinical condition, reason for transfer, and departure and arrival time, and there should be accompanying team. And you have to know the responsibility of the patient entirely depend on the peer team who is arranging the transfer till the receiving team accepting the patient. So it's a very important thing we have to know. We have received a lot of bad patients when during transfers, even from the base hospitals and other teaching hospitals to our centers. So the next thing is you have to know the first priority is patient rather than documentation. So you can hand over the patient to the clinical setting or ward, then change your clothes, change of PPs, then go for documentation. Don't wait for documentation before stabilizing the patient. So discharges, so these are the criteria which offered, circulars offered by last May, according to the general circular by Director General of Health Services. For immunocompetent patient who has mild symptoms, we can discharge after 10 days uh, if he's clinically fit and 4 days of home quarantine. So moderately severe symptoms, if he's clinically fit, we can discharge after 21 days with no further isolation is necessary. If you want to discharge this patient at day 14, you can discharge with of these followings, which include 2 consecutive real-time PCR, which is at least one should be done uh, after 11 days, and second one should be done after that 24 hours apart. Or there should be COVID-19 IgG positivity. So this patient you can discharge in 14 days, but they need 7 days home isolation. The time you should consider is the day you consider after onset of symptoms. So a lot of controversies happen during these discharges. You have to get this time from the symptoms onset. So immunosuppressive patients, all immunosuppression you have to keep involved in the institution for 21 days. So you can only discharge if they meets these criteria. They should have a 2 consecutive negative PCRs which has done 24 hours apart if you want to send the patient 21 days after. Or you can send the patient uh, with one PCR and positive serology, that mean IgG, that mean antibodies, that should be done after 14 days. So significant immunocompromised patient we mentioned in these slides. Uh, so if this patient is immunosuppressive therapies, cancers, bone marrow transplants, HIV patients, and immunodeficient patient, or if a consultant decides this is immunosuppressive patient, you have to consider this patient is immunosuppressive. So the follow-up, this is one of the most important part in a COVID-19 patient. Uh, so many patients has developed even severe manifestation like thrombosis after discharge, and some patient has gone to the respiratory deterioration even in the foreign countries after discharge. So you have to follow up, especially in symptomatic patient. You have to follow up in at least once in a clinic. So our patients, we used to follow up in every patient, every symptomatic patient in the clinic, because we are managing patient with the minimal facility even without x-rays. So what we do is, after discharge, we ask the patient to come to the clinic after 7 days with the x-ray. Then we manage independent x-ray findings and clinical findings. We try to do the referrals and arrange medical plans. So these are the one of our clinics managing in there. This is a clinic at Arachakand, and this is a clinic we manage at the Club Koggala village. And these are the data, these are the things we have done so far after third wave. In Arachikanda, we totally manage around 1,300 patients, and we have recovered 117 COVID-19 patients, and we couldn't recover. We have to transfer 15 patients, and we have detected 3 strokes, 1 Guillain-Barré, and we have encountered 11 deaths, and out of them about 5 deaths are related to the COVID-19. And in Club Choggal village, we have received about 100, 1,112 admissions, and we have recovered 37 pneumonia cases, and we have transferred about 30 pneumonia cases. And Club Bentote, we have a total 694 admissions, and we have recovered 3 pneumonias and currently being treated. There are 3 pneumonias currently being treated in a Club Bentote ICC, and we have transferred 3 pneumonias. And this is our centers. One of our center, which is DHR Chikanda. This is our main building, and this is uh, pictures of Club Koggala village. And this is my team in Club Koggala village. So I have a couple of take-home messages. So first thing is, COVID positivity is not a crime. You have to treat these patients as usual patient when you see in other wards. The next one is, successful COVID management is a good teamwork. Without a good team, you can't manage a COVID-19 patient. Irrespective of the resources, you can save a lot of lives. Best example is our centers. We have managed this patient by clinical assessment as well as minimal aid from the other investigations. And early detection is the key for the successful outcome. And do not misuse the steroid. The last, not the least, treat your patients, not the investigations. Whatever investigation, you have to assess the patient clinically. And my special thanks goes to my teams at my centers, DHR Chikanda, Club Koggala Village ICC, Ruhun Teachers Centers ICC, Club Bentot ICC. And special thanks goes to my fellow VP, Dr. Mrs. Samila Senaratna, and my patients who had really good faith on me on while managing with the in a resource, special resource poor settings. And there are a team who is playing a major role on coordinating these patients and patient management and the centers, which is led by Dr. Anwar Hamdani. The coordinating center COVID operations at the ministry. And level 3 care centers who received my patients, all my transfers, and they have done a lot to my deteriorated patients. I would like to thank them in this moment. And Government Medical Association Industry for letting us to present our findings and our experience in this forum. And these are one of couple of my references. And thank you very much for listening. I happy to uh, get if you have any questions. Till we have a question, shall we go back to our questions?
Yes, we have. Thank you very much, sir, for that very informative presentation. We have few queries.
Can you repeat the question again, please?
How to check the lungs when wearing PPE?
Okay, it's one of the good question we have encountered in initial part of management. Actually, it was uh, we have encountered. So this rabbit kit, actually, it is meant for. Actually, it was made for that Ebola pandemic. So which has very high infectious rate and the mortality and mortality. So with the rabbit kit, I don't think if you don't have a Bluetooth device, you can hear the lungs. So recommended PP for clinical examinations are: one is good mask or double mask, uh, face shield or goggles, good apron, gloves, and boots. So those are the necessary equipment you need to examine or go out and see the patient if it's not the aerosol generating procedure. So daily rundown, I only use those stuff, and I usually use a cap to cover my ears. That's the only thing I used. And so far, in our none of our centers has any breach. That means infection breach. So wearing that rabbit kit, I don't think you can examine the patients. And if you want to examine the patient through that rabbit kit, you have to use very hard earpiece. So I have changed my stethoscope in my centers for that. So without that, you can't examine the patient. Without examining the patient, I don't think you can manage the patients very well. Any?
Can both dengue IgM and IgG antibodies be elevated in COVID?
Yes. Yes. Uh, yeah, it's a very good question, and we usually encounter this question daily work downs. Uh, you can have both IgM and IgG. It has actually came out of the picture from Singapore initially. It has shown in Singapore presentation and the findings. It was actually documented initially from last 2019 November, December actually. You can have both IgG and IgM elevation, and it's a false positive value, not a real value. And if you have a fever, what you can do is do the NS1. You couple of patients, couple of centers I have heard they have encountered dengue and both cross infections, but usually one thing is predominant, either dengue or COVID. Our cases we have only encountered COVID patients who has falsely positive IgM, dengue, IgG, and IgA.
Where can we get D-dimers done for COVID-19 patients if not available in the hospital?
Uh, so another good question. So may any center is around. I mean, uh, so my centers are located in Goal, around Goal. So you have to discuss with the teaching. Only D-dimers available in the teaching hospitals. If I know, if according to my knowledge, it's only available in labs in teaching hospital. If it's a private sector, it will be available in any private sector lab, major private sector labs. So what you can do is through your medical administrator, MS or director, you can contact teaching hospitals and arrange the transfer facilities and transfer, and which should be available within 24 hours, otherwise you can't manage the patient. So if you have any suspicious, case, whether this could be a thrombosis. Do not wait for anything to start anticoagulation. Just start anticoagulation, send the blood samples, and depending on the samples, given the values, investigations, you can manage the patients. Do not hesitate to start anticoagulation if there's no contraindication. That's my only message for D-dimer issues as well as thrombosis, because we have seen a lot of thrombosis. Even with the anticoagulation, this is happening. So getting a D-dimer value is really helpful. So I'll share my recent experience. We have a patients with both parents had died in last 2 weeks, which was documented as a sudden cardiac deaths. We just did the D dimers. She has a 4,000 of D dimers with minimal excision or shortness of breath. So we have directly sent her for CTP and other stuff. So D dimer is very helpful, but you don't have to wait for that. You have to start the treatment even without D dimers. Get Try to get down DDMS from a teaching hospital or private sector. You can anyway always ask from teaching hospital help from teaching hospital.
What will happen when PCR is still positive before discharge after completing 14 days?
This is another frequent question we have encountered. For symptomatic patients, we have seen a lot of patients has positive PCR less than 30 CT value. So what we going to do is either you can keep the patient up to 21 days. That will be very difficult and patient was also very complaining. So you can do the antibodies, but unfortunately we don't have antibodies in every center. So even in Karapitia, they have very limited kits. So what we tend to do is we try to do the PCRs, 2 PCRs. If we can't, we had to keep the patient up to 21 days. Then you discharge the patient, disregard the PCR CT value. Or if you want to discharge the patients, you have to repeat the at least PCR about 3 days time. Unfortunately, in a private sector, you don't have a antibody test available at private sector. Due to there's no validation, no any provisions has been given for private sector to do antibody tests. So only in private sector we have to do the PCR. So in private sector, it's a lot of difficulty to manage patients discharges with these CT value issues. So in those cases, we have to keep the patient up to 21 days.
Can we manage O2 dependent patients without chest x-ray?
Really good question. This actually happened after third wave because we didn't have any transfers to manage. So it actually start with the third wave, as I said before. So your clinical assessment 99% type is correct. So if you don't have a place to transfer, if your patient is deteriorate, without waiting for the investigation, you have to start treatment. So that's the and only way to keep your patient safe, or only way to prevent that inflammatory response. So without necessary investigation, you have to manage some time for patients. So always get your senior opinion. So your consultant will be available in any time. I don't think without a consultant opinion you can't keep it. ICC, in ICC you can't keep the patient to manage uh, COVID-19 pneumonia. So if a place where you don't have a consultant coverage, you better transfer these patients. But in any COVID-19 secondary or tertiary care facilities now have very limited beds. So this is the reason we start to manage our patient without chest x-rays and other necessary investigations. But most of the times most of the time, in more than 99% of time we have succeeded. There can be other instances we are doing bad even with investigations, but unfortunately without none of my centers still don't have a chest x-ray facility. So we have around 150 recoveries, successful recoveries, which were all done without chest x-ray facility. So my message for you who has asked this question: don't wait just extra for the management. If you are not confident, please transfer or get the opinion from your consultant or seniors.
What is the etiology behind thrombocytopenia?
Is same as other viral infections. Or you see the dengue is due to the lot of cause antibodies, viremia. So many viral fevers, even influenza, we have noticed the thrombocytopenia, and it has shown also bad prognostic factors. But it's not a magic to have thrombocytopenia for viral infections. But when you monitor the thrombocytopenia, especially when you're giving the enoxaparin, if it's more than 50,000, you can start the enoxaparin. But you have to monitor very carefully, monitor the thrombocytopenia. Usually, if it's due to viral illness, it should come up to the more than 100,000 or 150,000 within couple of days. You have to monitor at least 2 to 3 times. Why is that? Because you are giving the enoxaparin. You can have heparin-induced thrombocytopenia at any time. So most important thing is monitor the thrombocytopenia during this stage.
Is testing for presence of antibodies compulsory prior to discharging symptomatic patients?
It's actually recommended in a lot of guidelines, at least test for antibodies, but not in Sri Lankan guideline. But the availability of antibodies is an issue. As I said, there's nothing, no labs issuing in a private sector. Only few labs, teaching hospitals have antibodies are available. So uh, we have discharged many patients without antibodies after clinical recovery. So it's good to have antibodies, but issue is we don't have enough resources to do the antibodies currently.
Should patients with history of home deaths of relatives due to COVID be closely managed? Then how?
Hmm, it's a difficult question to answer actually. Without getting a proper history, we can't be very sure this death due to the thromboembolism, sudden cardiac death, or and due to the hypoxic damage after hypoxia due to the COVID pneumonia. So even there's a pilot project going on home management. I think other centers without those pilot project patient without those filing without including those private project. I mean, the patients out of this pilot project, other patient all the patients should be managed at least in ICC. So uh, but our successful rate of our recoveries solely depend on the close monitoring. That means we detect early the hypoxia, that means deterioration. uh, so most important thing is get the medical opinion without being sent for the outside. So home death, that mean can be attributed to many things, but best thing is if you have positive or if you have suspect patient, please direct to the medical person who is competent to manage these patients. So as I mentioned, we have a history of one patient who has lost two family members. Unfortunately, we don't know whether it's a genetics or not. Unfortunately, he or she also had very high D dimers. Today, we have sent this patient for the repeat imagings for assess the risk of thrombosis and assess the presence of thrombosis. So it's very difficult question to answer. The best thing is send this patient for a treatment center, either ICC.
When do we have to go inside the ward and examine the
Yeah,
patients?
it's one of my questions actually. If you have enough PPs, if you have enough PP supply, you can't say you can't go and examine and treat the patients. If you have enough PPs, you have to go and attend to the patients, like we do in every center. So there are a lot of things inside, other than the COVID related or uncovid related, COVID related or COVID unrelated things within these patients, within these findings. So we have learned a lot of things, actually a lot of management points by examining the patient, and none of our members has got cross infection or any infection, because if you can use, if you can properly use your protective equipment, uh, you will not, most will you won't get infected, and most of the our staff members are vaccinated, so the risk is kind of very minimal. So my only message for these questions who has answered this, asked this question: examine the patients as much as possible, and in a possible way if you have enough VPs, which will ultimately give you a good outcome for your patients.
In the OPD setup, when a patient comes to you with respiratory tract infection symptoms, how and when to identify a patient whether to do PCR test or not?
Uh, During the COVID pandemic, if you have upper respiratory infection signs, symptoms, it's better to go ahead with PCR. Why is that? Or rapid antigen test. Why is that? The commonest thing we are worrying about the COVID-19. So apart from COVID-19, there are other viral infection on which is responsible. The commonest one is influenza and other viral infections, as well as bacterial infections. But without excluding the COVID-19, you can't safely manage the patient even at home or ward settings. So if you see a patient with the upper respiratory tract infection, signs of upper respiratory infection, go ahead with the rapid antigen test. It has a good sensitive value in a symptomatic patients. Or you have to go ahead with the PCR.
Someone wants to see the references slide again.
Yeah. I,
Could you please explain how far we should continue enoxaparin?
uh, the guideline recommendations I have mentioned, if a D dimers are high, you have to continue till the D dimers comes to the normal levels. What you usually in a resource 4 settings, we start therapeutic anticoagulation initially. Then, according to clinical recovery, we reduce to the prophylactic dose. When the patient start to mobilize very well, we omit the prophylactic dose. Usually, we continue till the patient is on bed bound or patient on the respiratory support. We usually use the therapeutic dose or prophylactic dose. So when the patient start to mobilize, and when she or she not on oxygen dependent, or he's clinically very much recovered, we actually omit. Usually we do not go beyond 10 days without investigation. If you have a D dimer levels, so we can guide our therapy according to D dimers.
When doing desaturation stress test, should patient wear a face mask or not?
Definitely, patient should not wear face mask, because there are a lot of mask-induced hypoxia we have noticed even in a medical team, among medical team. So you should remove the mask, then ask patient to have a walk. Actually, the salient sign is when the patient walk, they walk about 10 to 20 steps, then they stop with cough. That is a sign of hypoxia. When you just check the after the cough, they will have a aggravation of the cough. Then you just check the saturation, it should drop below the initial value of at least 3%. Then you go and examine, you will definitely have a lung signs. So when you have a typical lung signs, you can confirm, you can have a preliminary diagnosis of COVID pneumonia. Then without waiting the x-rays and other stuff, you better start treatment, and always get the consultant opinion before starting treatment, because all responsibility depend on the consultant. Because any HRCT, any X-ray will not be available at the moment. Maybe it will be available even in the best center. It will be available to 6 to 12 hours after. I don't think any of centers, because of the infection risk, it will be available soon. So uh, walking desaturation you should check uh, without mask.
Do we have to continue aspirin or any other drug after discharge?
It will only depend on the risk of cardiovascular status. So when you consider patient with a high cardiovascular risk, that means, for example, when you take a smoker who has diabetes, you still want to continue the smoking, you still don't want to quit the smoking, you better continue aspirin because he need according to the cardiovascular risk. In hospital stay, if you have a diabetes with a multiple condition, we tend to start aspirin, and we usually tend to continue for another 10 days and stop. And when usually we assess them at the clinic level, so depending on the cardiovascular risk at the clinic level, we stop the aspirin if there's no further cardiovascular risk is if we found.
After the COVID infection, how many days should we wait before getting the vaccine?
The recommendations are after infection is a 2 to 4 weeks, because just after infection you have very high antibody titers. The it may it may destroy your vaccine booster or vaccine. So that's a postulate they have made. So best thing is after 2 to 4 weeks you can get the vaccine.
We find patients with dyspnea, dry cough after discharge. How to manage them and any supportive measures. How about steam inhalation during COVID and after discharge? And for how long a patient can have post-COVID symptoms?
Um, First thing is steam inhalation. We are about to do in a trial in with steam inhalation with my foreign colleagues in our centers. In foreign studies, steam inhalation has not shown any benefit in upper respiratory infections. In COVID-19 also they have done some preliminary studies, but it has not shown any benefits. People think the general lay people think that warm inhalation will destroy the virus. It is a utterly stupid decision. It's will believe because after entering the virus, there's no destruction with the steam. At least 65 centigrade, you use 60 at least 65 centigrade a couple of hours, which is it cannot be done in a living person. So steam inhalation actually in foreign studies has shown some kind of harm due to the burns and other stuff. So this we usually do not advise prohibiting. I mean, we do not advise not to do any steam inhalation. It may be the placebo effect, but not the trial proven effect. But there's no major harms doing in a hospital stay even. So if some patient asks from me, shall I do this stimulation? I said, okay, you can do this stimulation, but this dry cough, it may be, or other symptom, it may be there for more than 3 months even, especially post-COVID apathy, malaise, and other symptoms like neuropathies. It can be last for long, but there's no actually specific treatment which has been shown other than improving mobilizations and improving activities gradually. So, but the best thing is we should assess them frequently after voice syndrome. What's the last question there was?
How long a patient can have post-COVID
Yeah, this
symptoms?
is about even I have not seen a patient after 3 months. So it is documented even after 3 months you can have post-COVID symptoms like I mentioned, apathy, malaise, and general well-being deteriorations also.
How to differentiate immune storm from other differential diagnosis?
How differentiate immune?
Immune storm.
I think they are asking about hyperinflammation. That means hyperimmune response. Okay. So When we see a rapidly deteriorating, or when we see the patient who is very deteriorated patient, I mean very uh, patient with uh, very bad pneumonia, their general well-being also very poor. That means they are dehydrated and their oral intake is poor. When you so if you have a chat with the patient who has recovered from the bad pneumonia, actually they will tell you how exactly the journey here they have gone through. Most of the patients have not remember what they have gone through. Actually they don't know what's happening. This cytokine is that kind of hard time to them. So when we go and examine first thing the history, their general well-being will shall tell you the patient, whether this patient is in an immune storm or at least you said hyperinflammation. Then the physical signs, that mean respiratory deterioration or clinical signs of COVID pneumonia. So with those are the clinical features of hyperinflammation, but uh, none of the guideline or none of the experts are recommending to treat the patient with only clinical signs of deterioration, the clinical signs of deterioration, except respiratory deterioration such as low saturations or hypoxia. If your patient have only the other deterioration, that means low blood pressure, do not treat with steroids. It may be due to something else, even dehydration. So, indication for steroid in hyperemulation only with the patient has respiratory deterioration. For example, if you do a HRCTs on asymptomatic or mildly symptomatic patient, you will see 8% of them have a COVID-19 changes, but they will recover by their own. So you're not going to do, we're going to do start a steroid on them. Only few of them, about less than 1% will go into prolonged changes. But so that's the reason. So even in the in asymptomatic population, you can have changes in HRC, but you're not going to treat them. So there's no clinical way to assess the hyperinflation, but medically, I mean, investigative wise, you can assess, but it doesn't mean you have to start treatment even. For example, with the high CRP or high IL-6 level, high ferritin, it your patient maybe have, but it doesn't mean you have treated the steroids. High CRP could be due to many things. Even high ferritin, we can have with many infections. So you're not going to treat for them. So only respiratory deterioration is an indication for the treatment, especially for steroids.
Is there any possibility of false positive rat?
Uh, that's one of the good question you ask. Uh, there is possibility of false positive rat. We have encountered many cases, about 10. So what we are going to do is, what how we encounter this problem is, uh, when you manage a pneumonia patient, should be very clear about the diagnosis. So if this symptomatic patient, uh, if you encounter symptomatic patient, if he only undergone a rat positivity, please do the PCR test to confirm confirmation or get the CT value. It will be helpful in the subsequent management. So uh, because of this rat false positivity in every symptomatic patient, that means in patients with pneumonia, you better go with the PCR testing at least once, not in others. Other thing I am to tell about rat, in a guideline, rat is usually recommended for these patients in guidelines. Either you have a possible contact history, either you have symptoms, either you have a possible contact history. Those three things should warrant this patient has COVID-19 with contact history with rat positivity. That means I'll repeat it again. One is contact history, one is symptoms, one is coming from the epidemiological area. Those three things should be there. to confirm you to make sure this patient is a COVID-19 with the red positivity.
Is there any way of allowing bystanders?
Um, yes, we have allowed some bystand in our center when they have a positive rat or COVID PCR only, or they have subject to the quarantine with the positive PCR or rat, or they are subjected to the inward treatment. That means subject to the ICC, even in ICC. That means if the rat or PCR positive, they were usually asked to go to the go to the treatment center, even an ICC. So those patients, so if and just think about the father is going in COVID pneumonia in my center, son is in another center. So you can get those bystanders who are not symptomatic to look after their own patients. So that's the only thing you can allow for bystanders without COVID positivity, without COVID exposure, or past COVID history, clearly mention past COVID history and recovered. You can't allow the bystanders to come in because you are exposing them for unnecessary risk. If you get down a healthy patient as a bystander, you are exposing them for unnecessary risk, even it could be result in death. So only bystander allowed with the COVID positivity, nothing else.
Should theophylline be avoided when treating symptoms?
Theophylline has not shown any benefits in a recent studies, even in the asthma, even acute severe asthma. But still, people have shown, and it has a very narrow therapeutic index if you use even in orally. So lot of I have seen lot of medical research who start in patient with theophylline. In actually, the COVID-19 is a kind of pro-arrhythmic condition. So with the theophylline, you can have a tachycardia, even of arrhythmias. So in my patient, I would generally avoid theophylline uh, while in the COVID-19.
What is called intermittent viral shedding?
Yes, this has been discussed previously also. The patients who had infected for virus with COVID-19, after recovery, up to 3 months, they can have a COVID PCR positivity. And some patients, you will see some time and time virus sheddings uh, due to the nasal carriage. But lot of studies done on this aspect, but most of them have shown those viral sheddings are not enough to cause an active infection or passive infections in many studies. And second category will have a patient with positive PCR even with the CT value low. So those are the actually after recovery the dead viruses. So PCR mean only they detected the RNAs. So two categories. Virus shedding can be happen in a very few patients, but it doesn't mean the major transmission can occur for these virus sheddings. And positive PCR up to 3 months is not signs of infection. It could be remnants of past infections. And if the patient do not develop symptoms, again, we do not warrant go for again for repeat PCR to test infectivity.
Is it necessary to get the vaccine after infection?
Yes, definitely you should get the vaccine after infection if it's available around you. Uh, why is that? There are instances in around world people have infected with the second time, and some of them results deaths. Very few of them result death. Getting a COVID-19 infection, it doesn't mean you will have a lifelong immunity. So it's very necessary to get a vaccine. Then you can have a immunity at least for acceptable time, at least a 1 year. So all recovered patient, we will recommend go ahead with the vaccination.
Last question, sir. How to manage the steroid usage and blood sugar levels in diabetic and non-diabetic patients?
So I'll go back to my slide again. I think I have a slide with that. Uh, right. This is actually from NHS guidelines. Uh, so if you don't have a diabetes or diabetic risk, uh, if you don't have a diabetes or diabetic risk, uh, even giving some dexamethasone, you will get a very high spikes of you will get not get a very high spikes of blood sugar like 300, 400. So every patient subject to the dexamethasone therapy, you should have a at least capillary blood sugar value before starting treatment, no fasting blood sugars. Or if it preferably, if you can have HbA1c, that's the best. So depending on that, we can start escalate our treatment. So when you starting when we have a patient has a high blood sugar, it doesn't mean you can't start steroid. Steroid indication, that means dexamethasone indication and the blood sugar values are two different things. If this patient indicate steroid, you should start steroid irrespective of blood sugars. But you have to control the sugar with the insulin, and with the consultant coverage, you can do it. That's what we have done. And make sure the hydration is good. And you have to start insulin for blood sugar control. Some people, even though this saying mixed start insulin is best, some people are using long acting insulin like a glarg insulin, glargines. So to overcome the resistance, we also have used long acting insulins for many patients. So recommendations are used humulin insulin, that means the mixed start one. But it will be preferable to the patient who has very well experienced. Some are very experienced with the soluble insulins, but giving soluble insulin has a major effect on hyperglycemic variability, which is causes very harm in ICU setup as well as HDUs. So preferably use long-acting insulin, so intermediate-acting insulins or premix insulins. Uh, but you should remember, depending on blood sugar value, you shouldn't de-escalate the dexamethasone dose. Dexamethasone dose should drive only depending on clinical status of the patient. You have to control sugars with hydration as well as insulin. That's the message I want to tell you regarding dexamethasone and sugars. So,
If there are no more queries, I would like to thank Dr. Himal CPD for his excellent presentation on behalf of GMO Free Knowledge Academy, and please accept our small token of gratitude.
right. Thank you very much for listening.
Thank you so much for the great audience, and here we are signing off for today. We'll meet you next week with another webinar. Until then, stay safe.